Sir, good morning, sir. Sir, listen, sir. Hello? 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 Am I audible?
Yes, sir. Yes, sir.
ఏం సార్ ఈరోజు ఇంకా ఎవరు జాయిన్ అవ్వలేదు?
వరలక్ష్మి
అందుకని లేడీస్ ఎవరు జాయిన్ అవ్వలేదా? అబ్బో
నేను అందుకే నిన్న శ్రీకాంత్ అడిగాను వల్ల చేద్దాం అంటే
శ్రీకాంత్ కూడా లేడు, అడుగుదామంటే. శ్రీకాంత్ ఉన్నాడా?
ఉన్నాడు సార్. స్టార్ట్ చేయమంటారు సార్, మీరు చెప్తే స్టార్ట్ చేస్తాం.
అదే సార్, ఒక్క నిమిషం ఆగేసి చూద్దాం. ఒక 10 మంది అవుతారండి అంతే. ఒక్క నిమిషం.
హలో.
స్టార్ట్ చేయండి సార్. రమణ ప్రసాద్ సార్, థ్యాంక్ యూ. శ్రీకాంత్ స్టార్ట్ చేద్దామా? శ్రీకాంత్ ఉన్నాడా?
సార్ స్టార్ట్ చేయమంటారు సార్?
అలాగే.
At the outset, good morning to all of you. మన గ్రూప్ మెంబర్స్ అందరికీ లక్ష్మీ కటాక్ష ప్రాప్తిరస్తు, వరలక్ష్మి గత సందర్భంగా I selected this topic even though I have attended only half a dozen transplant because the institution where I work, we are going to start renal transplant very soon. So at the end of the session, I asked my colleagues to put much more inputs who have worked in this transplant units. In 1954, Dr. Joseph Murray performed the first renal transplant among identical twins. Sir, am I audible, sir?
You are audible.
First transplant in India done in 1970. Kidney transplant is the most commonly transplanted organ. This is donor functioning kidney and recipient non-functioning kidney. Five-year survival rate in patient with transplanted kidney 70% compared to 30% in patients on hemodialysis. CKD, chronic kidney disease. Normal GFR is greater than 90 ml per minute per 1.73 square meters. Definition of CKD is structural or functional abnormality present in more than 3 months, like albuminuria, urine microscopic abnormalities, or radiographic urine abnormalities, or kidney disease by kidney biopsy, or by imaging census, or history of kidney transplant. All these things comes under the CKD. When the GFR is less than 15 ml per kg, 15 ml per minute per 1.73 square minute, it is called end-stage renal disease, ESD. Etiology of CKD, most common is diabetic nephropathy, followed by glomerular disease, then hypertensive nephrosclerosis, interstitial disease of the kidney, vascular disease like SLE, inherent kidney disease like polycystic kidney disease. Source of the donor, living and deceased. Living lo malli related, unrelated. Paid donor and pooled donor. Paid donor is otherwise called kidney swap. Here the two incompatible groups will donate one kidney to the other and vice versa. Deceased, non-beating heart, brain dead, beating heart. Matching between donor and recipient, ABO matching, tissue tracing done by 6 antigens located on the cell surface. Class 1 HLA-A, HLA-B, class 2 HLA-DR. Match between donor and recipient ranges between 0 to 6. Better HLA match, longer survival. Matching for DR antigen is more favorable. Donor lymphocytes and recipient serum test to determine if potential recipient has performed antibody, has preformed antibodies against HLA antigens of the potential donor. Cross match one transplant test. Evaluation of the potential living donors, ASA grade 1 and 2, pre-operative assessment, cross match, history, general physical examination. Investigation, CBC, blood group, correlation profile, RBT, FTS, viral markers. In this way, in addition to the routine markers, we do cytomegalovirus also. Lipid profile, urine culture, culture and sensitivity, chest X-ray, ECG. Laparoscopic versus open nephrectomy. Laparoscopic nephrectomy has some advantages like reduced blood loss, decreased tissue trauma, lower analgesic requirements, faster resumption of food intake, shorter hospitalization, quicker return to work, better post-operative cosmetic appearance. Disadvantages, technically more demanding. Nowadays, robo-assisted nephrectomy is also being done. Anesthesia for donor nephrectomy, general anesthesia, wide bore IV access, NIBP, mean arterial pressure to maintain renal perfusion, positive fluid balance, and preloading before induction, avoid hypothermia. Usually, kidney transfer 3 theaters, one theater donor, 1 theater per recipient. Donor nephrectomy, careful positioning, prevent pressure damage. Aim for urinary output of 1 to 2 ml per kg per hour. Mannitol improves outcome when adequate hydration in combination with mannitol compared to hydration without mannitol. Administered before ischemic insult, before arterial clamping in donor nephrectomy. Mannitol helps by expanding intravascular volume, free radical scavenging, increasing intrarenal prostaglandin production, and reduction in renin release. Postoperative pain, epidural analgesia, transverse abdominis spleen block, fascia transversalis block, quadratus lumborum block, paravertebral thoracic block. Donor intraoperative consideration. Aim for PaO2 of greater than 100 mm mercury. Adequate intravascular volume with HB 10 gram% and 30%. Systolic blood pressure more than 100 mm. Maintain urine output of greater than 100 ml per hour. Normopepnia, blood glucose less than 150 to 200 milligrams per deciliter. Use low dose dopamine or low dose epinephrine, high dose dopamine or epinephrine. Poor graft function and acute tubular necrosis. Heparin before application of the vascular clamps. Please remove and block with ureter.
సార్ కొంచెం గట్టిగా చెప్పరా, వాయిస్ కొంచెం డల్ తగ్గిపోయింది.
Renal transplant recipient. Pathophysiological changes. Cardiovascular disturbances, arterial hypertension, IHD, congestive heart failure, coronary artery disease, pericarditis, cardiomyopathy, dysarrhythmias, atherosclerosis. Respiratory disturbances, non-cardiogenic pulmonary edema, hypoalbuminemia and low plasma oncotic pressure, infections and risk of pneumonia, post-operative atelectasis, pleural effusion, hypoxemia. Normocytic, normochromic anemia causes deficiency of erythropoietin, decreased RBC survival, iron, folate, vitamin B12 deficiency, bleeding tendency, uremic osteodystrophy, osteosclerosis, osteitis fibrosa cystica, osteomalacia. Chronic inflammation, repeated samplings. Anemia, decreased tissue oxygen delivery and utilization, increased cardiac output, ventricular dilatation and hypertrophy, angina and heart failure. Increased bleeding tendency causes abnormal platelet function. Even though the quantity of platelets is normal, the adhesive property is disturbed in uremia. Renal loss of anticoagulant factors, bone marrow depression, PT platelet count are normal. BT is the screening test. Inhibition of cell-mediated immunity and humoral defense mechanisms. Infections are common at the fistula and catheter site. Wound healing is poor. Sepsis is the leading cause of death. Diabetes mellitus, stiff joint syndrome, otherwise Prayer sign is positive here. Autonomic neuropathy, peripheral neuropathy, electrolyte imbalance, diffuse atherosclerosis, hyperglycemia and ketoacidosis, hypoglycemia. Neurological abnormalities, central and peripheral nervous systems involved. CNS changes vary from mild personality alterations to encephalopathy and convulsions. Peripheral neuropathy, autonomic neuropathy, delayed gastric emptying, postural hypotension, silent MI. Gastrointestinal disturbances, anorexia, fluid and electrolyte derangement, hypervolemia, pulmonary edema, hyperkalemia, dysarrhythmias, hypocalcemia, osteoporosis, hyponatremia, hypermagnesemia, hyperuricemia, hyperphosphatemia. Acidosis, decreased myocardial contractility, decreased SVR, impaired response of central cardiovascular system to exogenous and endogenous catecholamines, rise of potassium by 0.5 to 1 millimoles per liter for each 0.1 unit decrease in pH. Dialysis related problems, dementia, dialysis disequilibrium, hypotension, systemic anticoagulation. Perioperative management, preoperative evaluation of the recipient, history, cause and its duration, any medications, dialysis. Dialysis charts అన్ని వెరిఫై చేయాలి. డేట్ ఆఫ్ లాస్ట్ డయాలసిస్ నోట్ చేసుకోవాలి. ప్రీ డయాలసిస్ అండ్ పోస్ట్ డయాలసిస్ బాడీ వెయిట్ మెజర్ చేసుకోవాలి. ఇఫ్ ఇట్ ఈస్ loss of weight is more than 2 kgs, that is called dry weight loss. You expect hypotension during induction and during operation. So you should always weigh the patient before dialysis and after dialysis, and the weight loss should not be more than 2 kgs. Cardiac symptoms, exercise tolerance, symptoms of gastroesophageal reflux. Examination of general physical examination, CVS and CMS. Evaluation of the renal function, creatinine, electrolytes, urine analysis, ABG, HbA1c, and CBS, ECG, ECO, chest X-ray, PFT, blood grouping and cross-matching, INR, APTT, platelet count. Thorough history, physical examination to identify any active cardiac conditions such as unstable pulmonary syndrome, decompensated heart failure, significant arrhythmias. Non-invasive testing should be considered in patients without active cardiac disease, but who are more risk factors associated with pulmonary artery disease. You have to do abdominal stress tests or myocardial perfusion scintigraphy when there is comorbidities like diabetic mellitus, duration of dialysis greater than 1 year, LVH, age greater than 60 years, smoking, hypertension, dyslipidemias. Continue all concomitant drug therapy, omit ACE1 inhibitors and A or B drugs, receptor blocking drugs, angiotensin receptor blocking drugs. Dialysis should be finished 4 to 6 hours prior to surgery. Post-dialysis investigations, optimize electrolytes preoperatively, pre-medication, prophylaxis for gastroesophageal reflux. Immunosuppression to decrease the incidence of graft rejection. It is divided into 3 phases. Induction therapy started before and during the first week of post-transplant. Maintenance therapy to prevent acute graft rejection and induce tolerance. Third phase involves lifelong immunosuppression. Conventional regimen, a calcineurin inhibitor, cyclosporine, corticosteroids, antimetabolic, mofetil or azathioprine. Antibody induction regimen, usual low doses of the conventional medications with the addition antibody directed at T-cell antigens, anti-lymphocyte antibodies, that is thyroglobulin, OKT3, or interleukin-2 receptor antagonists, like mesiliximab, datlizinumab. Selection of anesthesia usually performed under GA with intubation can be done under regional anesthesia. General anesthesia provides a stable hemodynamics and excellent muscle relaxation. Monitoring, standard ASA monitoring, ECG, MIBT, pulse oximetry, capnography, temperature during the output monitoring. CBT monitoring, invasive blood pressure monitoring, neuromuscular junction monitoring, pulmonary capillary wedge pressure monitoring. Proper positioning and paddling of the extremities. Padding and care of arteriovenous fistula. Do not monitor blood pressure on the same arm. AV fistula is usually done on the left arm. Risk of thrombosis in fistula. Do not use the arm for venipuncture. Monitor adequacy of the blood flow through the fistula using Doppler advice. So, in some institutes, when there is no available Doppler, if the nephrologist asks you to assess the function of the AV fistula, you should murmur. Once the AV fistula after surgery is done, it gets matured by 3 months. So you should use it for dialysis after 3 months only. Induction agents, propofol, pharmacokinetics is minimally affected. No adverse effect. Use in 1 to 2 milligrams per kg. Etomidate metabolized by liver. No adverse effect. Used in 0.2 to 0.4 milligrams per kg. Thiopentol increases the sensitivity, decreases free circulating carbohydrates, and decreases protein binding. Acidosis increases entry into the brain by increasing non-ionizing fraction, and in sometimes blood-brain barrier is disturbed in CKD. So you have to reduce the dose of pentothal sodium to 2 to 3 milligrams per kg. Keep them in the minimally changed. The dosage is same. Inhalation agents. The inorganic fluoride toxic levels were more than 50 to 80 micromoles per kg. We've seen in sevoflurane. So the best inhalation agent is desflurane and isoflurane, where their inorganic fluoride levels are very less. Sevoflurane is degraded by soda lime to compound A. Compound A is nephrotoxic. So soda lime containing barolime, sevoflurane, when you are using the FGF of less than 1 liter per or 2 liters per minute, you should not use in CKD. Opioids, morphine. It is metabolized in liver to morphine 6-glucuronide, which is potent and may accurate. Should be avoided in CKD. Fentanyl, most commonly used. It is excreted, 7% is excreted in renal and kidney unchanged. Fentanyl is inactivated by liver and excreted by urine. All fentanyl significant accumulation does not occur. So all fentanyl, remifentanil, and fentanyl, they can be used in CKD. Benzodiazepines, midazolam and diazepam, hepatic metabolism with urinary elimination, active metabolites accumulate, increase the sensitivity in hypoalbuminic patients. So dose reduction should be done by 30 to 50%. Muscle relaxant, succinylcholine. It is safe if there is no hyperkalemia. Serum potassium is 5.5. You can use succinylcholine. More than 5.5, you should not use. Cisatracane is the drug of choice by plasma stridulalysis and non-enzymatic Hoffman inhibition. Vecuronium, primary hepatic metabolism, 20% is eliminated by the kidneys. So if you use less than 0.1 milligrams per kg dose, it will have prolonged effect. So interval between the doses should be increased. Propyronium, hepatic elimination, but prolonged action in kidney disease can be used if appropriate neuromuscular monitoring is available. Pampironium is 90% dependent on renal excretion. Universal drugs can be safely used in CKD. Anesthetic consideration, prevention of aspiration, avoid stress response to laryngoscopy, avoid hypotension, hypovolemia, fluid hemostasis, maintain renal perfusion, avoid hypoxia, hypercarbia, altered pharmacokinetics, electrolyte disturbances like hyperkalemia, hypocalcemia, acid-base disturbances, metabolic acidosis, arrhythmias, conduction blocks, infections, complete reversal of neuromuscular blockage. Surgical procedure. Left kidney is preferred because of long left renal vein. Sorry, there is a that is long renal artery is wrong. Left kidney has long left renal vein, whereas right kidney has right long renal artery. So previously left kidney is preferred. Nowadays right kidney is preferred because of they want anastomosis long renal artery. Left kidney is placed in right lumbar quadrant in extraperitoneal or retroperitoneal position. This places pelvis and ureter anteriorly and facilitates reconstruction. Renal vein is anastomosed to external iliac vein. Renal artery is anastomosed to external iliac artery. Ureter is implanted in a bladder after irrigating with antiseptic solutions. But in children weighing less than 20 kg, kidney is placed intraoperatively behind the right column. Factors affecting the kidney viability: living donor. A standard donor is 5 to 50 years of age. Who do not have hypertension, who did not suffer from CDA, whose creatinine is less than 1.5. Extended criteria for kidney donor is age more than 60 years, who has hypertension, who has suffered from CDA, and whose creatinine is more than 1.5. Factors affecting the kidney viability: cadaveric kidney. Best are from donors with brain death having stable hemodynamics and adequate respiratory parameters. Unfavorable, donor having primary renal disease, history of cardiac arrest or prolonged hypertension, advanced age, use of potent vasopressors, presence of oliguria. So the total ischemia should not exceed warm and cold ischemia more than 1 hour. Warm ischemia is 3 to 5 minutes. Cold ischemia should not exceed half an hour. Preservation depends on minimizing the ischemia time. Begins with the donor vessels clamped and up to when kidney is perfused with cold preservation fluid. The preservation is 2 types: hypothermic cold storage, static. Another is pulsatile machine perfusion with a hypothermic solution. Usually 4 degrees centigrade or 0 to 10 degrees centigrade. Agents when the kidney placed in the recipient and terminates when vascular anastomosis is complete and perfusion by the recipient begins. Warm ischemia is more deleterious. Increased risk of acute tubular necrosis should not exceed more than 3 to 5 minutes. Cold ischemia, kidney preserved better 4 degrees centigrade to slow down the metabolic process. Kidney solution containing heparin and mannitol. Solution have an electrolyte composition similar to intracellular environment. Low sodium, high potassium, thereby preventing loss of cellular potassium. Cold ischemia time in a living donor should be restricted to 20 to 30 minutes. Intraoperative goals: aim CVP 12 to 15 millimeters of mercury, systolic BP 130 to 160 millimeters of mercury, mean arterial blood pressure greater than 80, IV fluids of at least 30 to 50 ml per kg per hour. Higher infusion rate should be given during the ischemic phase, at the time of donor clamping and before declamping. So, high
ఆర్టికల్ పెట్టాలా సార్ ప్రతి పేషెంట్ కి?
declamping.
రామప్రసాద్ సార్,
సార్
ప్రతి పేషెంట్ కి ఆర్టికల్ లైన్ పెట్టాలా?
పెట్టుకుంటే బెటర్ సార్.
రైట్.
Graft turgidity is assessed by the surgeon. Maintain intravascular volume and avoid decreased perfusion. Balanced salt solutions are the fluid of choice. 0.9% NaCl is the most commonly used intraoperatively. Potassium containing fluids like lactated vinegars are avoided. Colloids, severe intravascular volume deficits who require high volume resuscitation. Hydroxyethyl starch, medium molecular weight solution and easily degradable, and it can be used. Other colloids should be avoided because of there is increased bleeding complications. Albumin and endogenous colloid can be used in patients with a large fluid deficit. Aggressive volume expansion with more than 0.8 milligram per kg of albumin has been shown to improve the outcome. Blood transfusion. Most patients are accustomed to anemia and significant loss during the operation is rare. Normal loss in the kidney transplant is average to 500 ml. Transfusion should be performed reluctantly, better done after decranting. Use of vasopressors, ephedrine, phenylephrine, norepinephrine should be avoided due to risk of vasoconstriction, but may be used to treat refractory hypotension. Diuretics, furosemide, Lasix 100 milligrams, loop diuretics act on ascendingly properly and counteract the response of ADH to surgical stress and facilitates diuresis. Mannitol decreases the ischemic reperfusion injuries through scavenging of free radicals, decreases the endothelial swelling. Others like a calcium channel antagonist, verapamil, increases the renal blood flow and improves the graft survival. Papaver is also used intraarterially to decrease the spasm, arterial spasm. Dopamine routine use not recommended, insufficient evidence for improved survival. Intraoperative anuria and oliguria. Mechanical causes, renal vascular complications, arterial stenosis or thrombosis, venous occlusion or thrombosis, post-renal outflow tract obstruction by clot, thinking or edema, leakage of urine at ureteral vesicle junction, increased pressure on the transplant kidney by hematoma formation. Non-mechanical causes, hypotension, hypovolemia, acute tubular necrosis, acute rejection. Intraoperative challenges, cardiovascular complications, design, intraoperative hemodynamics, hypertension. How do you treat hypertension? Adequate medication and NTC. Hypotension, avoid continuation of angiotensin converting enzyme inhibitors and ARBI, angiotensin receptor blocking drugs on the day of surgery. Intraoperative potassium and glucose levels, hyperkalemia, hyperglycemia, diabetes, hyperglycemia, hypoglycemia, ketoacidosis, risk of silent MI, sickle cell disease. To prevent further ensure adequate hydration, good oxygenation, normothermia. First operative care, neuromuscular blockade reversed and extubated. Mostly do not require ICU admission. Intravascular volume status and urine output should be monitored closely. Sudden decrease in the urine output may warrant surgical re-exploration. Transplanted patient requiring prolonged mechanical ventilation postoperatively have a poor outcome. Pain can lead to agitation, tachycardia, hypertension, and increase the risk of pulmonary complications. Epidural analgesia, patient controlled analgesia, non-steroid anti-inflammatory drugs should be avoided. Contraindications for renal transplant, ABO incompatibility, cytotoxic antibodies against HIV antigens of the donor, recent malignancy, active infection and sepsis, AIDS, severe cardiac pulmonary hepatic disease, active vasculitis or glomerular nephritis, non-compliance and psychiatric illness. Persistent coagulation disorder, pregnant women, relative contraindications, pediatric abnormalities, aortoileic stenosis, morbid obesity. Summary: live donor, laparoscopic donor nephrectomy, anesthetic technique, general anesthesia, patient controlled analgesia with a regional block from TAP or QL block, preoperative hydration 100 ml per hour crystalloid starting midnight before surgery, IV bolus colloids 5 ml per kg before induction, caution with induction dose of propofol, especially in hypertensive patients, invasive hemodynamic marking not routinely required, start mannitol infusion 0.5 grams per kg after induction up to the time of nephrectomy. Intraoperative infusion of 20 ml per kg per hour of crystalloids. Target mean arterial pressure of normal or plus 20% of the patient's normal. IV bolus colloids 5 ml per kg before institution of pneumoperitoneum. Aim for a perfusion pressure to a value of intra-abdominal pressure added to the mean arterial pressure. Intra-abdominal pressure usually is 12 to 14 centimeters of water. So you should add, aim for a MAP of 80, 80 plus 12 is 19. So the perfusion pressure of kidney is, you should aim for that pressure. If suggested infusion volumes are unable to improve perfusion pressures, low dose dopamine infusion 1 to 2 micrograms per kg per minute should be initiated. Aim for urinary output of at least 100 ml per hour. IV dexamethasone 8 mg. Technique of choice and immunosuppressants will be administered in the ward. Caution with induction dose of propofol for recipients. Titration of response is necessary to avoid excessive and protracted periods of hypotension. IV infusion of thyroglobulin to be started after central line infusion over 4 to 6 hours for recipients at high immunological risk. Arterial line to be injected as needed. Infusion of non-potassium containing crystalloid is to be initiated. Goals of therapy include CBP 12 to 14, systolic blood pressure of 130 to 160, mean arterial blood pressure greater than 80, total IV fluids of at least 30 to 50 ml per kg per hour, stroke volume variation less than 15% to be interpreted appropriately in combination with other parameters. Higher infusion rate should be given during the ischemic phase at the time of donor clamping. Graft rigidity as assessed by the surgeon to run a 250 ml of crystalloids initial bolus and assess further boluses if required until rigidity improves. Serial monitoring of ABG and electrolyte status. Mixtures of Renal lactate and balanced crystalloids may be required in worsening acidosis. Caution with potassium containing crystalloids for cadaveric recipients. In refractory hypotension not responsive to crystalloids, colloids may be used to optimize intravascular volume. Vasopressor to be used only after volume therapy has been optimized. Boluses of ephedrine or phenylephrine may be given for refractory hypotension during initial stages prior to transplantation. IV infusion of 20% mannitol 0.5 grams per kg to be initiated 30 minutes prior to unclamping. IV methylprednisolone 500 milligrams to be infused at the start of anastomosis and completed before arterial unclamping. So mannitol methylprednisolone should be given before unclamping. Post-reperfusion hypotension to be managed accordingly based on kidney fragility as communicated by the urologist and depending on the volume status. Adequate volume to preempt the use of vasopressors. IV furosemide. Total intraoperative fluid administration should be about 30 to 50 ml per kg per hour. Aim for early extubation. And after unclamping, there may be fall in the CDT 20 to 50%. This is due to maybe due to reperfusion or release of nitric oxide. So immediately post declamping, you should maintain the hydration status, giving the more intravenous fluids or colloids. Thank you. One more point. The main aim of hemodialysis is cleaning clearance rather than fluid removal. The ideal age patient for kidney transplant is estimated GFR less than 20 ml.
Sir, regarding fluids for the colloids, what would be the colloid of choice, sir?
Hydroxyethyl starch.
Why not gelatin, sir?
It is just the bleeding.
Sir?
Bleeding problems.
I think starches also have that issue if given in volume.
Hydroxyethyl starch, they say that it is molecular weight is less and it does not cause bleeding. Sir, Srikanth sir, Mohan sir, any valuable inputs?
అలాగా సార్, మీరు లాప్రోస్కోపిక్ చేయొచ్చు, చాలా బెనిఫిట్, బ్లీడింగ్ తగ్గుద్ది అన్నారు కదా.
Sir.
అదొకటేనా, ఇంకేమైనా బెనిఫిట్ ఉంది? మీ దగ్గర లాప్రోస్కోపీ చేస్తున్నారు కదా శ్యామ్, మొత్తం రీనల్ ట్రాన్స్ప్లాంట్స్.
ఎస్ సార్, డోనర్ అన్ని ల్యాబ్ సార్. Recipient they open sir, donor matram lab చేస్తారు. And even after that there will be a larger incision to take out the kidney. But definitely analytic requirements చాలా తగ్గాయి సార్.
సో ల్యాబ్ చేయడం వల్ల ఒకటి బ్లడ్ బెనిఫిట్ అయినా ఇంకేం బెనిఫిట్ లేదా?
ట్రామా చాలా తక్కువ సార్, అనాలిసిక్ రిక్వైర్మెంట్స్ చాలా మినిమల్ గా ఉంటాయి. ఫెంటనిల్ ప్యాచ్ పెట్టి సరిపోతున్నది.
ఎన్ని కేటీలు చేస్తారు మీరు?
వీక్ కి మంత్ కి 1 or 2 ఉంటాయి సార్.
సో బ్లాక్ లో చేయొచ్చా?
ల్యాబ్ యూజువల్ గా మరి అంటే CO2 గురించి చేస్తున్నాం సార్.
ల్యాబ్ కాదు, మామూలుగా రిసిపియంట్ కు మీరు బ్లాక్ లో ఏమైనా ఇస్తారా పెయిన్ కి?
నేను ఎపిడ్యూరల్ వేసుకుంటున్నాను సార్.
సార్ ఎనీథింగ్ ఎల్స్ రమణ ప్రసాద్ చెప్పండి.
అదే సార్, నాకు my experience with the transplants, I have only attended 6 or 7. Experience is less, but I want to refresh the memory, so I have opened this.
అంటే మా దగ్గర మేజర్ ఇష్యూ ఎప్పుడు కూడా డోనర్ హైడ్రేషనే సార్. If the donor is adequately hydrated, then usual గా మనకి యువతల వైపున తక్కువ ప్రాబ్లమ్స్ వస్తుంది.
Shyam, you have experienced any fragility of this kidney? Surgeon saying this is classic.
Yes sir, if the mannitol timing is an issue for the donor sir, ఎగ్జాక్ట్ గా ఈ క్లాంపింగ్ కి 15 minutes ముందు ఇస్తే కనుక ఇతలే పెర్జిడిటీ బాగుంటున్నది. ఈవెన్ ఇఫ్ ఇట్ జాస్ ఆఫ్ బై అట్లీస్ట్ 10 minutes, there is going to be an issue.
Are you using verapamil or epaverin?
No sir, no sir. Main, if the kidney is hydrated on the donor side, usually on the recipient side output is coming immediately.
What preservative you are using?
Sir,
preservatives. I said vinegar lactate or something, mannitol and heparin.
They are not using mannitol sir, heparin and lactate.
Not using pulsatile machine perfusion.
No sir.
So you first flush the kidney with saline.
Yes sir, saline and means the mixture that the means lactate and other mixture will be there, no sir. They'll flush it.
All the transplant patients you are extubating immediately, or you have any experience of ventilating this patient?
Only one patient I had to extubate the next morning sir. Most of the times they are extubated on table.
Are you reserving any blood for this patient?
Yes, sir. Always for all patients, I reserve 4 points, sir.
4 points. But
Yes, sir.
the book says the loss of blood is only 500 ml.
Yes, sir. Means if there is no loss of blood, we don't transfuse. But if there is a loss of blood, usually it would be more than 1 liter.
How many ports are there? Single port or the?
No, sir. Usual minimum of 3 ports, sir. Maximum would be 5 ports.
Position?
Lateral, sir. Usually they take out the left.
And place in right leg. Yeah?
Yes, sir.
Sham, you are not using, there is no requirement of colloids, no, nowadays for transplant patients.
No, madam, I routinely use colloid, madam.
What actually it is, nowadays they say that even that is also increasing the crystalloid ratio of 1 to 1:1.4 only, no? Is there?
Madam, the issue is the volume, what is it, maintaining the map above 100, madam. To chase that with crystalloid, the volume that is needed is much higher. With colloids, I am getting stable hemodynamics very quickly. That's why, madam.
Are you using albumin?
But recommendations say that it is only it will increase the colloid to colloid ratio is only that increases by 1:1.43 or 1.4.
That is still a decrease in 300 ml every liter, na, madam. That is still a decrease in 300 ml every liter, na, madam. Otherwise, almost 5 to 6 liters is sometimes needed to maintain the turgidity. Otherwise, the surgeon will keep on saying kidney is flaccid.
Okay, then we can do one study, no, in that.
Yes, madam. Yes, madam. We can definitely do a study.
You should always maintain the renal perfusion pressure, as Sham said.
ఏం స్టడీ చేయాలి?
అసలు colloids తో బెనిఫిట్ ఉందా లేదా అని సార్.
అది పెరిఫెరల్ రీనల్ లీకేజ్ ఉంటుందని చెప్పి వద్దంటారా? ఎందుకు అది?
They interfere with the coagulation, so bleeding is much more. So only hydroxyether starts as less coagulation.
The issue is practically doing, and in the book, and it's a lot of differences there. We need to know practically everybody does it, but what is actually supposed to be tell in the exam? శ్యామ్, మనకు బుక్స్ రీసెంట్ దాని ప్రకారం ఏంటి ఉంది మనకి అది ఎవిడెన్స్ ఏంటది?
సార్ రీసెంట్ గా అయితే ఆల్బమిన్ పెట్టమని చెప్తారు సార్.
0.8 milligrams per piece.
ఇది 4% ఆల్బమినా?
5%.
5%.
దగ్గర దొరుకుతుందా?
నేను వాడట్లేదు సార్. ఇక్కడ మా దగ్గర ఉన్నది 20%.
అంటే కాస్ట్ ఎక్కువ అని వాడలేదా?
అంటే నాకు ఎప్పుడు అవసరం పడలేదు సార్. అంత ఏంటంటారు, ప్రెషర్స్ మెయింటైన్ కాలినట్టు పెర్ఫ్యూజన్ ఇష్యూ రాలేదు ఇప్పుడు వరకు.
Any recent original articles regarding the transplant anesthesia, Sham?
నేను చూడలేదు సార్.
రామ్ ప్రసాద్ గారు, రీసెంట్ ఏమైనా రామ్ ప్రసాద్ గారు? రీసెంట్ ఎవిడెన్స్, రీసెంట్ ఆర్టికల్స్ ఏమైనా ఉన్నాయంటే స్టూడెంట్స్ పనికి వస్తాయి కదా, పీజీ స్టూడెంట్స్ కి. మన డిఎన్బి మీ దగ్గర ఆర్టికల్స్ ఎక్కువ ఉంటాయి కదా శ్యామ్, కొంచెం ఐనూలు ఏమైనా ఉంటాయి కానీ చూస్తావా?
ఇవాళ పంపిస్తాను సార్, నేను షేర్ చేస్తాను.
గుడ్ ఆర్టికల్స్ ఉంటే ఇట్ విల్ బి థర్డ్. సో ఇట్ విల్ బి గుడ్ ఫర్ వెరీ నైస్. ఇంకేమైనా ఉన్నాయా క్వశ్చన్స్? డోనర్ రిసిపియంట్ వాటికి కాకుండా ఈ బ్లాక్స్ ఇస్తారా మనం రిసిపియంట్ కి ఏదన్నా అదర్ దాన్ ఎపిడ్యూరల్ మన ఒకవేళ ఎపిడ్యూరల్ ఇవ్వకపోతే డూ వి గివ్ ఏ క్యాప్ బ్లాక్ లాంటివి ఏమైనా ఇస్తారా మామూలుగా? అంటే పోస్ట్ సర్జరీ అబ్డామిన్ లో ట్యాబ్ బ్లాక్ ఏమైనా ఇస్తామా?
ట్యాప్ ఇచ్చినా కూడా రిక్వైర్మెంట్ ఎక్కువగానే ఉంటున్నది సార్ యూజువల్ గా, అందుకని ఎపిడ్యూరల్ ఈజ్ మోర్ కంఫర్టబుల్.
ఎపిడ్యూరల్ మనం పోస్ట్ ఆప్ మనం ఎంత 1 డేకి తీస్తామా 2 డేస్ తీస్తామా?
నేను 3rd డే తీస్తున్నాను సార్.
3rd డే.
ఎందుకంటే నథింగ్ ఎల్స్ ఈజ్ యూజువల్లీ నీడెడ్ మనం ఎపిడ్యూరల్ వేసుకుంటే కనుక. అంటే ఒకవేళ పొరపాటున డ్యూరల్ పంక్చర్ అయినా కూడా ఐ పుట్ ఇట్ ఇన్ ది స్పైనల్ అండ్ అడ్జస్ట్ ది డోస్ అకార్డింగ్లీ.
అంటే 0.25% ఇస్తారా పెయిన్ రిలీఫ్ కి?
0.125 సార్ రోపిన్, సారీ సెన్సర్ కెన్ 0.125.
Why don't you use ropin?
Sir, and anyway, means longer acting is not needed, sir, because it is a continuous infusion. And 0.125 తో అంతగా మోటార్ బ్లాక్ కూడా ఏమి ఉండట్లేదు సార్. They are able to move their limbs within an hour.
లేబ్రాల్ చేసే డోస్ అదే కదా?
Yes, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.